Good morning. My name is Rob Corelli, and I'm a pharmacist on the faculty at the UCSF School of Pharmacy, and my colleague Erin Hudmon is from the College of Pharmacy at Purdue University. So today we're excited. We love talking about medications for smoking cessation, and let's move on. Get the next slide. Okay, there are actually recommended by the U.S. Public Health Service 7 medications that are considered first line, and these are all FDA approved for smoking cessation. There are 3 that are available over the counter, non-prescription. Obviously, anyone can purchase these. These include the nicotine gum, nicotine lozenge, and the nicotine patch. And we're going to talk about all of these in detail. Again, prescription medications, there actually are 2 formulations of nicotine that require a prescription, which I always tell, when I'm talking about these, it makes me kind of laugh a little bit that anyone can purchase nicotine in a cigarette without a prescription. However, you have to have a prescription to buy clean pharmacologic grade nicotine in the oral inhaler, which we'll talk about, as well as the nasal spray. So 5 formulations of nicotine replacement therapy. And then we have 2 tablet formulations that do not contain nicotine, bupropion SR, also the trade name for that is Zyban, and then Chantix or varenicline. Okay, so again, we're going to go through sort of the pros and cons of these 7 different agents and spend some detail on that. So we can go to the next slide. First, I want to talk about nicotine gum and lozenge, and we really do like to combine them because they are in so many ways very similar. They are both nicotine delivery systems that are used within the mouth. Okay, so the gum and lozenge, and again, as I've said before, already are available over the counter, no prescription necessary. They come in 2 different strengths. Individuals who smoke their first cigarette of the day are within 30 minutes of waking are considered to be more heavily dependent on nicotine. They need that nicotine dose early in the morning, so they should start off with a higher dose strength, 4 milligram. The 2 milligram is reserved for those that appear to be less dependent. We take advantage of the fact that nicotine is well absorbed across the lining of the mouth. Now, both the gum and the lozenge actually are altered. The pharmaceutical companies add antacid, essentially, that allows the nicotine to be well absorbed across the lining of the mouth. Variety of flavors with these agents. Key thing we like to mention with patients or people that are trying to quit smoking is that these are best used on a regular schedule. That is, every 1 to 2 hours while awake, not just as needed, because these medicines don't work as fast as a cigarette. Now, for the gum, there's a very special way that this has to be used. It's not like regular chewing gum. As I said, it's a nicotine delivery system. And patients have to chew the gum to release the nicotine and then park it between their cheek and gum. And then the medicine is slowly absorbed. You'll feel a tingling sensation when that gum is activated. Once that tingling dissipates, the person chews again and then reparks in another area of the mouth. So again, we don't have a lot of time right now, maybe in the Q&A, but bottom line is, well, it's gum. It's not to be chewed like regular gum. It has to be used in a certain way to be effective. We could go to the next slide, and this will be a theme that we'll have with all of the medicines. We'll kind of go the pros and the cons. Now, the pros for the nicotine gum, it's an oral substitute for tobacco. People who have something in their mouth appreciate having something in their mouth, whether it be a gum or a lozenge. Now, what's nice about this medicine is it can be used. Now, we use the word titrate here, meaning that it can be used. People can adjust their own dose to manage their withdrawal symptoms. They can go up on the dose, chew an extra piece of gum, use an extra lozenge as needed, if they need it, in addition to their regular scheduled dose. Studies have shown that people who use the nicotine lozenge and gum don't have the immediate weight gain associated with quitting. So for individuals who have huge concerns about weight gain, this may be an option. We will hopefully talk about this in the Q&A, but we recommend use of nicotine gum and lozenge frequently in combination with the nicotine patch, which we'll talk about. And the gum and lozenge can be used as needed for situational cravings for tobacco. Because these are available generically, they're relatively inexpensive, and for most individuals cost less than a pack of cigarettes, at least nationally. The cons: frequent dosing. These have to be used every 1 to 2 hours, which can cause poor adherence, meaning that people don't follow it and get the best results. These products can have some GI side effects. When I say gastrointestinal, stomach upset, hiccups. Individuals who have significant dental work, braces, dentures, the gum is not a viable option. Again, I've talked about chewing technique is important for using this correctly. And then there are just people that don't like gum. Okay, so that's the question we always ask. They don't like to chew gum, so it may not be a good option for them. Okay, we can move on to the patch. And this is the most commonly used medicine for quit attempts in the United States. About 3/4 of people who quit with medicines use the patch. It's available in a variety of doses. Individuals who smoke more heavily, is more than a half a pack a day, need to use the 21 milligram. The big advantage of this product is that it's once daily dosing. You put a patch on and it delivers its dose over 24 hours. It can be used in combination with other short-acting nicotine replacements, the gum and the lozenge, inhaler and nasal spray. And it's of all of the nicotine replacement therapy products, it's the most discreet. You can put it under your clothing and no one really knows you're using it. And again, these are also available generically and so are inexpensive relative to the cost of tobacco. The cons for this really are that you don't have a lot of adjustment with this. When you put a patch on, it's passively delivering nicotine across the skin. So if you have an urge for a cigarette or have an urge for tobacco, you can't just put another patch on because they don't work right away. So that's one of the cons and why we recommend routinely combination therapy, patch with a short-acting used as needed. And because it's an adhesive patch, it is not recommended for use in individuals who have any kind of underlying serious skin conditions, psoriasis, eczema, severe contact dermatitis, etc. So let's move on to the prescription forms. Now the inhaler, and I hope you can appreciate by the photo on this slide that is not what you think of when you think of an inhaler, like for asthma or COPD. It's a cartridge in that little plastic cartridge. There's 10 milligrams that is actually delivered via that mouthpiece. Individuals just inhale in short puffs to the back of their throat, and the nicotine is actually absorbed again across the lining of the mouth. It also has that oral substitute you have with the hand, that hand to mouth, because it's actually brought to the mouth, is similar to a cigarette. Individuals can titrate, again, with the gum because it's short acting. That mimicking of the hand to mouth, some individuals really like that, have something to do with their hands. And again, it can be used in combination, particularly with the patch, as needed for situational urges. When it's used by itself, like the gum and the lozenge, it needs to be used every 1 to 2 hours. So poor adherence or the inability to use a medicine that frequently, which is really up to 9 times a day during the initial courses of treatment. The cartridges are less effective in cold environments, and of the nicotine replacement therapies, this is one of the more expensive agents, and we'll have a slide devoted to that later. If we could move to the last nicotine replacement therapy, the nicotine nasal spray. Of the nicotine replacement therapies, this is the medicine with the most rapid onset. Okay, within 15 minutes, people will start to feel the nicotine delivery. So it has a faster onset. So individuals who want a more rapid hit of nicotine, this is a more effective delivery system. It also can be used in combination with other agents to manage situational cravings for tobacco. It's short acting, so similar to the gum, lozenge, and inhaler, needs to be administered every 1 to 2 hours while awake during the initial course of treatment. The biggest challenge with the nasal spray, number one, most people in the United States don't like nasal spray, so that's always a challenge for us. And number two, it can be irritating to the nasal mucosa, the lining of the nose, and so tearing, sneezing, burning upon application are common side effects that people need to consider before using this. Individuals who have underlying sinus conditions or severe allergies, this is not a viable treatment option. Absorption can be compromised through the nose in that setting. And similar to our other prescription nicotine replacement therapy, cost of treatment for the nasal spray is also significantly higher than it is with the other forms of NRT, or nicotine replacement therapy. And I believe Karen was going to be talking about our non-nicotine, so I'll pass on the microphone to Karen.
We have two tablet formulations. We have Zyban, which is available in a generic, and we also have Chantix, which is currently not available in a generic. So bupropion SR, or Zyban, where SR stands for sustained release, has been on the market for a very long time. It was initially marketed only as an antidepressant, but it was determined, a physician in Southern California noticed that many of her patients who were being treated for depression using this medication had lesser cravings to smoke, and they were smoking fewer cigarettes per day, and therefore it was then studied as an anti-smoking medication. The benefits are twice a day, daily dosing, oral, taken by mouth, which is, patients like that. Simplicity is good. It could possibly be beneficial for patients with depression, and it can be used in combination with nicotine replacement therapy, and specifically, typically with the nicotine patch. And there was a study that was conducted at the University of Wisconsin that evaluated the impact of adding these two medications together, and there is an FDA approval indication for this combination. It is inexpensive if you use a generic formulation. There are some downsides associated with the use of bupropion SR. Specifically, there are several conditions that we need to screen for to ensure that it is safe for patients to use the medication, specifically because the seizure risk is increased. And granted, it's not terribly high, but it is 0.1%, and this is dose related. So higher dosages can result in higher levels of, or higher incidence of seizures. But the doses that we use for tobacco cessation tend to be lower than what we use to treat patients for depression with the same chemical agent. But it does require more extensive screening. And we also need to monitor for potential neuropsychiatric symptoms, very similar to what we monitor for with Chantix. And back in December 2016, the FDA removed the boxed warning off of both the Zyban bupropion SR and the Chantix drug labels as a result of an FDA study, commission study that evaluated the drug-related side effects of these products and also the nicotine patch, and there was a placebo group, and determined that the neuropsychiatric effects like suicidality and other very serious potential consequences were not drug-related. So they removed the black box warning off of the labels. However, we continue to monitor these patients for side effects. Next slide, please. Okay, so this is our newest drug, and I say new in quotes because it's really not that new at all. In fact, in 2020, it will go off of patent. And it's dosed similar to Zyban, which I did mention. You start at a lower dose and you increase over time, over several days, to get to a regular dose of taking 1 tablet twice a day. What's new about Chantix is that it is a different mechanism than the other products. It's different than bupropion SR, and it's different than nicotine replacement therapies. And we also know as a result of studies that it is the most effective medicine. It has the best success when used alone compared to all of the other medications that Robin has discussed, and it is better as well compared to Zyban. It's available in packaging for a starter month box and then a continuation box. And the way that the medication is labeled tells the patient how to take it, which helps with adherence. There are a few downsides of the medication. One is the cost of treatment, and I'll review the cost of all these therapies on the next slide. But the other is nausea, and several patients will, not quite a third of patients will experience some nausea. However, this can be improved by taking the medication after eating a full meal and with a full glass of water. It does cause some insomnia, and it can also cause some sleep disturbances, and that's because the medication works at the same location, same receptor sites in the brain where nicotine works, and it actually creates some stimulation, not as much as you would get with nicotine. So if you're using the medication twice a day, you're having some level of stimulation at night, and that can lead to the sleep disturbances. And as I mentioned with the bupropion SR, we have to monitor patients for the same types of neuropsychiatric symptoms. Next slide, please. This chart demonstrates the different costs of use of pharmacotherapy, and when you think about it compared to the cost of a pack of cigarettes, which is around $6.26 nationally, what we see is the cost of medications are generally less if you're using the over-the-counter products, or if you're using a generic bupropion SR. The other ones tend to be a little bit more, but we need to remind patients that these medications are used for a short-term period as opposed to long-term, the rest of their life, which they might be using tobacco for. So there is a cost benefit that patients consider, but at the end of the day, it's going to cost far less to use medications if they're able to quit successfully than it will be to continue smoking. And I think there we'll go to question and answers.
Great, thanks so much, Robin and Karen. That was great. A nice overview and reminder of all of the FDA-approved medications and the differences in the over-the-counter and prescription choices. Are there any questions from the group? I have a question. I'll start. Let me ask a couple questions. The cost, can we go back to the cost slide? So for a lot of our patients that are at our health centers and then the residents of public housing, cost is of course a big deal. I'm interested, do you all have any information about Medicaid coverage for the nicotine nasal spray or inhaler? I know it varies by state, but I was just curious what the general landscape is for Medicaid coverage.
Yeah, I'll take that. That's a real challenge, and that's where part of these are very much underused. What happens across many of the Medicaid plans is they will not necessarily be covered, or when they are covered, they're in a higher tier. So the copay for patients is quite a bit higher. So, we work with our plans, at least working with pharmacists, we train them to actually help and work through the prior authorization process for individuals, because for the nasal, for example, the inhaler is one that we'd like to recommend frequently, especially in combination. So my suggestion is to have your clients work with their pharmacists in their area, because some plans will cover, it ranges. We have plans, at least speak to the California landscape, where there are plans that cover all medications with no copays, to others that will cover, they traditionally will cover the patch gum and one of the oral agents, or bupropion as well, which is generic. So yeah, the cost for that is can be prohibitive for those, but they are a viable option for individuals, and they just have to work through their health plan for that. And then because the other piece of this is, while we show the cost per day on that particular slide, that is the cost for the usual starting dose of the medication. The nasal spray and the inhaler, they come in a whole month's supply. So the cost of that prescription is usually approximating close to $500, which for most people is a challenge. So again, needing to work through your insurance with that. I don't know if Karen, if you wanted to add something to that.
No, just that it really varies by state. So, and sometimes at different points, tobacco quit lines, for example, Indiana right now is offering 2 free weeks of nicotine replacement therapy that could start them. And so there's different opportunities, but again, every state is different. Every plan is different. You need to figure out what it is in your state, your location.
Yeah, that's great. Yeah, thanks, Robin and Karen. And I liked what you were saying, Karen, at the end there about, there is a high cost up front, and clearly, $400 or $500 for one prescription all at once is hard on many people. But the cost over time and quitting smoking, in the long run, that kind of messaging is helpful, I think, to help patients understand, like, there is some investment and cost up front, but this will help you really save money and save your long-term costs of not being sick with chronic disease and not being able to work and all of those things too. Those are interesting conversations.
Yeah. Sorry, for some patients, it's sometimes difficult to put a $50 bill on the counter when they can put $6 for a pack of cigarettes. And so one of my students actually had a lovely idea, and they said, why don't they ask their friends and family members each to donate $5 toward their first quit attempt box, and then after they save their money from the cigarettes, they can pay them back. And I thought that was a really good idea.
I like that. That's a really good idea. That's a really good idea. I like that. That's unique and innovative. I have not heard that. I would use that for sure in my practice. I like that.
So in the chat box, we have a question. There seems to be a bit of education that has to go along with the gum. Do you find that patients are able to adhere to the recommended usage, or, in other words, does this affect successful quit attempts?
Yeah, one of the big challenges, and Karen and I have actually studied this in at least actual utilization of medications for quitting. And what we know is that, and this is in a plan, just to put this in perspective, that is a dual eligible, so Medicare, Medicaid population, very underserved population, have absolutely no copays for any medications, no limitations on quit attempts. So again, I would call this the Cadillac of coverage. And we've looked at over a 12-year time period, just utilization of medicines. And we actually have drilled down on adherence for these. And what we know is that even under those ideal conditions, that individuals, only a third of patients receive the minimum recommended treatment duration. That is, that whole adherence piece, that whole taking the medicine as prescribed. So we know that they're not using these. And something that has to be taken, for example, gum, lozenge, inhaler, and nasal spray, something that has to be taken 9 times a day, that's a challenge. That's difficult, which is why I will tell you that we routinely recommend, when we use nicotine replacement therapy, routinely recommend the use of combination. Patch on the background, delivering medicine slowly across the skin. You don't have to worry about it. And then using a short-acting as needed. Now, you heard Karen present the data that varenicline is the most effective agent when used by itself. We know that the second most effective treatment long-term for cessation is the combination of nicotine replacement therapy. And I'll tell you that individuals, when patients hear that, actually lots of times providers, can you use those in combination? Is that safe? And the answer is absolutely, that is safe. And the light bulb goes off. It gives people this idea that, oh, I didn't know that I could actually have the patch, but if I feel like I want to smoke, I can use something else as needed to help me. So I hope that that's something that you encourage among your clients, because that really is really one of the most effective. We know that it's right up there with Chantix, far superior to the other ones when they're used by themselves.
Yeah, and I would even go as far to say that I would discourage the use of only a short-acting agent because of the adherence issues.
Yeah, that's great. That's super helpful, Robin and Karen. I think you're right. Oh, go ahead, Frank. Go ahead.
I'm sorry. I just want to tell you this real quickly. So about 15 years ago, I did a small study that was not published, and we gave everybody either the patch, the gum, or the lozenge, and didn't tell them anything about how to use it. And the concept, the idea was to see how they would use it. And I did the follow-up with everybody. Every single person that had the nicotine gum said exactly the same thing to me when I asked them if they had read the directions on the box. They all said some variation of, how stupid do you think I am that I can't chew gum? What are you talking about? So in many cases, especially with the gum, not only don't they follow the directions, they don't even know they're there. So it's very important. And a very simple thing all of you on this call can do is make sure that people read the directions and understand how to use the product. I got the kind of response from the patch people and the lozenge people, but almost to a person, everybody who was on the gum said that to me.
That's great. Yeah. Go ahead. No, go ahead, Robin. This is super interesting. I have to say, well, let me real quick. I'm like fascinated because these are things. So I'm a family physician, Robin and Karen. You don't know that about me. And in my clinical practice, I know I have not given good instructions on how to use the gum. So now I'm like, fascinated. Like, of course, nobody's, it's not working for anybody because I haven't set them up for success. I've set them up for failure. So I find this really interesting. So go ahead, Robin, and then I have one ending question, and we'll. Yeah.
Sorry to talk over you. And yet, just due to the nature, we normally include a slide that actually goes in great detail the gum chewing technique. And just it's important for people to know, that the gum, if you chew it like regular chewing gum, you markedly increase the chances for side effects. So people will have that stomach upset because you're causing rapid release of nicotine, stomach upset. And then probably the one that people wouldn't think of is hiccups. So almost invariably, if someone says, I use this and I got hiccups, if they're using the gum, I know they're chewing it like regular gum, or if they're using the lozenge, I know they're chewing the lozenge, right? So things to think about when those come across, that people don't like it because they have side effects, and it's often because they're just not using it the way it's been studied and found effective and the way it's been tolerated.
That's great. And one comment we got from Katie in South Carolina is that South Carolina Medicaid covers all 7 meds with no copay or prior authorization and applies to all MCO health plans across the board.
That's great. That's lovely. I always love to hear that. That's so great. And I think Linda's, they follow kind of Medicaid coverage. So did you want to comment on that, Linda?
Not on that. I actually wanted to ask about duration of use. If you could say a little bit about the term of use of these medications. And also, we get a lot of questions from people about long-term use of gum, you know, for a year or two after quitting. And I was wondering if you could say a little bit about that as well.
Sure. That we didn't put on here. Maybe it would be helpful for this group. We have a one-page handout that really summarizes very succinctly all of the medications. It's actually pretty much everything we've said on this call and includes the recommended duration of therapy. But on average, most of these treatments are recommended for I'm going to say on average because there's some slight variation, but it's anywhere from 10 to 12 weeks of treatment is the recommended duration of therapy. For all the nicotine replacement therapy, the intensity, the dose is higher in the initial 6 weeks of treatment. And that's because we know that for people that are quitting smoking, the withdrawal symptoms typically peak in the first few days and start to slowly dissipate. After usually 2 to 4 weeks after quitting, people don't really have the nicotine withdrawal symptoms. Again, this is on average. It's the behavioral aspects, the habits, the routines associated with tobacco. And that's where, you know, of course, we partner very closely with our quit lines. And it's nice to see so many quit line folks on this call because we can connect individuals who actually, the trained professionals that can actually help with those very important behavioral aspects of quitting, which are they're equally, in some ways, more important than the withdrawal. So, Linda, so that's really the recommended duration for most individuals. But I say most, and I think one of the fun things about working in this clinical space is every quit attempt, every person is unique. And so we look to the duration of therapy. Some individuals need longer courses of therapy. When I say 2 to 4 weeks is the typical duration of withdrawal symptoms, some people have prolonged withdrawal symptoms, and we need to address those and not ignore that, and they may need more medicine. So you'll hear about even higher doses. So we just provided the basics, but I think clinicians that work in tobacco cessation know that sometimes people need more nicotine replacement. They may need combinations of drugs. We use combinations of bupropion and our Chantix and Zyban with, you know, we use different combinations for more difficult individuals who are struggling with quitting. And maybe the last piece, if I understand, just to jump on, is the long-term gum. And we all know, any of us who work in tobacco cessation know that there are people that are on long-term treatment and they can't quite get themselves down off the gum. And our end game is always to get somebody off the medicine. You don't need to be on these treatments for life. It's not like an antihypertensive or a diabetes medicine. We know that if somebody has the potential to relapse and go back to tobacco, it is far safer for them to be on what we consider to be pharmacologically, clean nicotine. It doesn't have all of the cancer-causing agents, carbon monoxide, some of the other toxic agents. So we always work, and we have people that we work with to get them completely off and taper them more slowly. But that's my perception. I would love to have Karen and Frank join in and with their thoughts on this as well, particularly on the long-term treatment.
Yeah, no, I'm in a complete agreement.
Linda, this is Frank. So years and years ago, I worked on something called the Lung Health Study, which was a COPD research project. And some of the group, people in the study quit smoking, obviously. That was the whole point of it. But we followed these people for 7 years, and we got medical records on them every 6 months. And a small percentage of the people in the study ended up being on the gum for over 5 years for various reasons. And so what happened is, even though this wasn't an initial thing they were looking at, we ended up having another smaller study looking at long-term effects. And I can tell you for sure that there was nothing, not one untoward effect from anybody from being on the gum that long. Not that I recommend that, and I know Karen and Robin don't recommend that either, but even if somebody does stay on it, it's certainly preferable to smoking. It was published, if you want to look that up, but it's been a long, long time, so I don't know if there's anything more than that, but I can tell you for sure that there were no issues with anybody.
That's great. Thanks, Frank. Thanks, everyone, for your great questions. It's good to know. Obviously, like long-term use of gum is not maybe recommended or preferred. It's nice to know about the data that says that we haven't, seen any real huge safety risks. So that's super helpful. Thanks for the great didactic, Robin and Karen. Appreciate you joining us today.